Okay, let's continue our second topic, outpatient care systems. So in this topic, we need to know the features of new models of primary care and enhanced primary care. And also we should know how to apply the two models to the disease management programs. And also we need to know some differences between comprehensive geriatric assessment and geriatric evaluation and management, the two assessment and management systems. And also we should know some innovative options for geriatric specialty outpatient care and some complementary methods to identify the patient with high risks who can benefit from the new system. Okay, the topic we're going to cover, including geriatrics in primary care, specialty care, and patient selection for outpatient interventions. So the reason we want to introduce the new models because in the traditional outpatient care system, the care providers, those doctors don't want to see the older patients with so many problems and complaints. So they think that they need to spend more time, but with less income. So which means that they spend more time to the patient and they can only charge the patient for like 20 minutes or 30 minutes. If the patient stays there for like more than 1 hour or 90 minutes, they cannot charge more money for those patients. So I just give you an example of that. So that's why they prefer to treat a young patient in order to save time to see another patient. So in the same time, they can see like a 2 or 3 young patients instead of one older patients in order to get more income. So that's why that's a problem for the traditional care system, primary care system. So in order to solve this problem, we introduced the new model in order to give both benefits for the primary care providers and the patients. So the new model integrates geriatrics into primary care and also involve geriatrics as a primary care specialty. So the first model is a patient-centered medical home, aka PCMH. So this one is build a very strong and long relationship between the patient and care providers. So the care providers give patient individualized treatment plan based on their personal goals, like long-term goal, short-term goal, and their expectations. So the physician treat the patient based on those aspects. And the practice adopts a whole person orientation that provides or arranges for all of the patient's healthcare needs. So basically, this is the first model. The second one is called Comprehensive Primary Care Plus, aka CPC Plus. This one is based on the first one PCMH model, but have some extra functions, including access and continuity, care management, comprehensiveness and condition coordination, patient caregiver engagement, and planned care and population health. Next one is primary care first. This one is based on the CPC Plus model and also has some extra functions, including more focus on the doctor-patient relationship, enhancing care for patients with complex chronic needs, try to reduce administrative burden and focus on financial rewards. The last one is accountable care organization. This one is more focused on the full continuum of care. So in order to give patients long-term care, and so basically in this model, the provider-led organization that may take many forms, including large integrated delivery system, physician hospital organizations, and independent practice associations. So basically these are the new models. I just want to briefly give you an introduction. So let's go back to the geriatrics in primary care. So here I want to give you some more details of this one. So the definition contains a lot of aspects, and it's very comprehensive. It contains something we talked before in those new models, like like providers give patient an individualized, goal-oriented care plan, and based on patient's preferences, and also it focuses on ongoing review of patients' goals and care plan, like a continuum, and also continue information sharing and integrated communication with the patients. So basically, these are all information included in this kind of care plan. And also here are some key elements, which is also for those aspects we discussed before. So the models of enhanced primary care contains guided care and grid team care. So let's talk about the first one, guided care first. So it's designed to improve the quality of life and the efficiency of resource use for older patients with multiple morbidities. And it aims to enhance primary care, and there's a specialized team to take care of the patient, including the RN, PCP, and office staff. And so actually it's a small team to take care of the patient. And based on the clinical trial, this model can benefit both patient and the primary care provider. The second one is called Geriatric Resources for Assessment and Care of Elders, aka GRIS model. So in this model, an intensive medical home for high-risk older patients will be focused. And also there will be a more comprehensive interprofessional team will be involved in this model. So including nurse practitioners, social workers, and pharmacists, and it's central. So the team will meet each week to talk about the patient information, and also to update patient conditions in order to make appropriate treatment plan for each patient in time. And also each patient will receive an individualized care plan developed around common geriatric conditions. And also this in this model, the clinical trial showed a lot of benefits for the primary care providers and the patients. So for the disease management programs, it focuses health care delivery around a single disease with the goal of optimizing patient care for that disease. So for example, if a patient have a heart failure, or the patient have a depression or Alzheimer's diseases or diabetes or chronic kidney diseases, they can definitely get benefit from this model, and it's very cost effective. And for the comprehensive geriatric assessment, it's one of the options for the outpatient consultation. So it aimed at determining a patient's medical, functional, and psychosocial capabilities and limitations, and develop a plan for treatment and long-term follow-up. And the CGE, coupled with the strategy to improve PCP and patient adherence with the recommendation, has demonstrated improved outcomes as well. Another option for the consultation is the geriatric evaluation and management. This one's more intensive compared to the CGA model. So a geriatrics interprofessional team will be involved for the diagnosis and treat the problems for the patient. And also the team also provides more monitoring and coordination of care between visits through regular telephone calls. And also the clinical trial to show the positive results for this system. For the geriatric specialty care, so here we want to introduce you the senior health clinic. which is a specialized ambulatory clinic service center for older patients, and mainly provides primary care user interprofessional team approach to develop and implement a plan of care. So for those facilities in this model, I believe all of you are very familiar with that, which includes skilled nursing facilities, associated living facilities, nursing home, home care, and hospitals. So basically, it links patient with the community-based service and the information, and also delivers very good primary care with an integrated healthcare system. So the core team for this model, including geriatrician, NP, social worker, geriatric nursing specialist, and also it has an extended team which contains pharmacist, PTOT, dietitian, nutrition, and its home health nurse. The provider team share a common medical record and meet weekly in order to discuss patient conditions and give patient appropriate treatment. So when SHC patients are admitted to the hospital or SNF, care is delivered directly and are coordinated by SHC providers. The patient in the HSC clinic can have a better mental health and a better health-related quality of life. So basically, definitely, patient will have a lot of benefits using this system. And the SHCs are revenue generators when considered within an integrated health system because of a downstream hospital and professional fees. And also, this model has the potential to thrive because it can focus on high-risk Medicare beneficiaries that can deliver high-quality care at a lower cost. So the medical fee for service coding. So for this topic, for this section, I want to let you know how can the new models give some benefit for the care providers. Remember, I mentioned that in the traditional primary care system, the providers don't want to treat older patients because of long-time meeting, but with a low income. So this is how the new models can help the care providers get some compensation by treating those older patients. So basically, the first one I want to introduce is chronic care management. So the billing code can be used in outpatient assisted living, home and nursing home setting, and the service can be billed by physician or non-physician practitioner per calendar month, and only one practitioner can bill CCM per service period. So basically, any care providers in the system can use this code to bill the patient. And also, we need to know what kind of patient is qualified for this system, for this billing code system. So first, there are two criteria. First one is patients with two or more chronic conditions expect to last at least 12 months. The second one is a chronic condition place patient at a significant risk of death, acute exacerbation or decompensation, functional decline. So basically, those patients with two or more chronic conditions, and also for those patients with life-threatening conditions, should be qualified for this system. And also, there are a lot of services that this system should be included in this billing code system. And so here are those services. And there are three types of CCM codes. First one is the regular CCM code, which is a principal care management service. So patient only requires 20 minutes per month of care management service. Second one is complex CCM mode. So in this mode, if a patient is so complicated, has so many complaints or so many problems, So care providers can bill the patient for an initial hour of time over the course of a month, and also can bill the patient with additional 30 minutes maximum in order to get some extra compensation. And the third one is a transitional care management code. So by using this code, the physician, not only the physician can receive reimbursement, but also their staffs can also get some extra compensations by seeing the older patients. So here's another system which is called a Program of All-Inclusive Care for the Elderly, aka PACE system. In this system, its goal is to keep patients in the community for as long as it is medically, socially, and financially feasible. So it combined Medicare, Medicaid funding allows PACE to integrate acute and long-term care. And also in this system, it's needs a really comprehensive interprofessional team, including all of those PCP, geriatrician, NP, PT, OT, social worker, pharmacist to get involved. So most enrollees are eligible for Medicaid because otherwise the program carries high out-of-pocket expenses, and a few insurance plans cover the PACE system, and their criteria is very strictly. So they only allow patients at age 55 or older who is eligible for Medicare and who is also certified by the state as eligible for care in a nursing home, and also who is living in the defined geographic catchment area to qualify for this system. So you can see that the criteria is will screen out most of the patients to the system. But the research has shown that this system really provides a high quality care for those patients. Okay, so next section is about patient selection for all patient interventions. For the patient selection, initially, so when the patient see their PCP, they can be referred by them to our geriatric clinics. But those PCP may lack time, skills, and incentives as we described before. And also in order to address this problem, we design screening questionnaires. So the first one is the probability of a repeated admission survey. So it contains the risk score based on patient age, sex, health conditions, and then they can validate many different populations of community dwelling older adults in order to get a whole picture of what's going on for those patients. And basically, this is one of the questionnaire in order to help us to screen those patients. And also we have the Vulnerable Elder Survey 13, which designed 13 questions for those patients. And we screen the patient based on their answers and give patients a score to see if the patient qualify for the system. And also we have predictive modeling. We analyze the patient information based on their health insurance enrollment records, and use the data to make an analysis and in order to see if the patient qualify for the system. So here's a summary of this topic. So we first discussed about the new models of the geriatric primary care, and also we discussed the new CPT coding system in order to benefit both patients and primary care providers. And also we talk about how to identify the high-risk patients and who are likely to benefit from the new models. Okay, so here are some questions I would like you to have a look, and please take your time so we can discuss the answer later. Okay, what's the answer? Do you want to go back to have a look of the first page? Okay. Okay, the answer is A, chronic care management. Because remember, as we discussed that in this model, so it requires patient who has at least two chronic conditions which expect to last for more than 12 months, and also for the patient who has life-threatening conditions. So definitely this patient qualify for this model, and also it only needs a small team to take care of the patient, including PCP, a nurse, and office staffs. So in other models, which is which is very cost effective. So in other models, you can say that B, C, D, they all need to recruit new team members. So especially for the C, it requires a very comprehensive interprofessional team to take care of the patient, which need need to do a lot of new assessment for the patient, and it's not cost effective. So actually need to patient so basically so it needs more money to be invested for those the other three models. So that's why the first one is best options. I can copy and paste the answer to the chat box later, so you can have a look of the detailed explanation. So here's the second question. Okay, what's the answer? Yeah, answer B, comprehensive geriatric assessment, because this patient has a very complicated condition. She has a B cell lymphoma, so which requires all of those assessment and physical therapy and also a psychiatrist to come to make an evaluation for the patient, and also definitely primary care evaluation is also needed. So you can see that the comprehensive geriatric assessment contains all three answers, the other three answers options. So and also can give a patient a more comprehensive evaluation and treatment plan. So that's why the B option is the best one. So as I mentioned, I will copy and paste the answer in the chat box so you can have a look. So do you have any questions? Okay, if you have no questions, I wish you have a good rest of the day. So see you.